Good morning, everyone. I would like to welcome you to this month's edition of the COVID-19 Research Monthly Meetings. My name is Sandra Chilengi Sakala from the National Health Research Authority. And I just want to say a warm welcome to everyone, and I hope and pray that we are all keeping safe in these hard times. I see that we have a good number, and it's already 10, so we can already get into the program. So just before we do, I just want to mention that this is a monthly program.
Okay. Good morning, everyone. Madam Didi has fallen off the connection. She'll be connecting very soon.
Sorry about that, I fell off. As I was saying, this is our monthly meeting, which we hold every last Wednesday of the month. And so we just want to encourage others that may be interested in presenting their research findings on COVID-19 to get in touch with us. We always send out an email to invite presenters, and you can also reach us by phone. There's Mambo on this platform. I'll just ask him to come through just in case there's any announcements he wants to make, but that will be your contact person. And then we'll get straight into the presentation. I think I have seen that our presenters have already logged in, and so we'll quickly get started. Mambo, do you have any announcement? As Mambo is coming, I just want to mention that we are going to have, okay, he's here. Mambo, could you guide our presenters on timekeeping issues?
Sure. Good morning once again. So I'll be showing some time slots for the presenters as they are making their presentation, just to guide you on how far you, or how much time you are remaining with. So I have two flyers that I'll be projecting. There's one for when you're remaining with 2 minutes. I'll be showing this on my screen, and then when it's time up, I'll also show up another flyer just to show you that the time is up. So we have a total of 15 minutes to make our presentations, and then we'll have a 5 minutes Q&A session after the presentation. We'll see how the presentations will go. We might have the Q&A, a combined Q&A session, or we'll have a separate Q&A question for each of the presenters. Thank you, Chair.
Okay, Thank you so much, Mambo. So with that guidance of time, I think we can get straight into the presentations. This meeting is supposed to take just about 1 hour. And because we only have 2 presentations, I think it will be possible for us to get to one topic. Once it's presented, we get the questions and answers, and then we move on to the next one. So we will get started. Patricia, Maritim, and Prof. Joseph Mumba Zulu, I hope that you're ready. You can already start sharing your screen. Just to mention that the duo are coming with a study titled Assessing Health Research, Health Systems, Readiness and Preparedness, and Ethical Considerations in Implementing COVID-19 interventions in Zambia. So you are welcome. Please take the floor. Thank you.
Hi, everyone. Are you able to hear me clearly?
We can hear you, but I think a bit faint. I'm not sure if it's just my speaker, but maybe try to move to the microphone as close as possible, just in case it's not just me. Trying to see. Okay, I think my volume was low, but yeah.
All right. Thank you very much for the introduction. My name is Patricia Maritim. I will be presenting some of the work that we've been doing as part of an implementation research interest group based at the University of Zambia School of Public Health. And in particular, the work we'll be talking about today is an assessment of health system readiness and preparedness, and how ethical concerns and dimensions have been integrated into the COVID response in Zambia. So, as you are all aware, COVID is an acute respiratory disease that is caused by the coronavirus. And the first case of COVID was declared on the 18th of March in 2020. And since then, there have been almost 192,000 reported cases through community transmission, which is the main mode of spread. And in response to the rising number of cases, the government instituted the development of the COVID-19 multi-sectoral contingency and response plan, which is geared towards strengthening the preparedness and response to the pandemic. So some of the measures that are supported under the response plan include surveillance, case management, increasing access to laboratory diagnostics and infection prevention and control, as well as risk communication to increase adherence to prevention measures, and more recently, with scientific advancements, the rollout of the vaccines. So as we have seen across the different regions of the world, we are learning that the containment of COVID-19 is very challenging, where health systems are weak, and this is more common in low resource settings such as our own. So studies that have evaluated health systems that are resilient in the wake of COVID spread and other epidemics have shown that when a health system has high level of preparedness, this is usually linked to positive outcomes such as effective detection, proper reporting, and adaptive responses that are able to mitigate and rehabilitate damages that arise due to health emergencies. Now, whenever we are making decisions as to how we should decide what public health measures or social measures should be rolled out in response to rising numbers, these decisions should be based on implementation considerations such as their potential acceptability, their feasibility, as well as their effectiveness. But aside from that, ethics play a really critical role in determining how we should roll out these interventions. And it's important for us to evaluate how ethical principles have been incorporated in any response. But if you look at the research that's coming out, there's been very little research that are looking at how health systems are responding to the pandemic within the context of ethics. So for the purposes of this study, we felt like some of the measures that are being put in place, infection prevention and control, surveillance, a lot of those interventions have already been shown to be cost effective and they're readily available. But even as we are implementing this intervention, we've seen, based on evidence both locally and across the globe, that the pandemic disproportionately affects vulnerable communities in the sense that they have inadequate access to supporting environment that promotes the adoption of health promoting habits such as sanitation, such as adherence to wearing masks, and also in terms of access to treatment for patients who have severe cases of the disease. So utilizing a health system approach, which is what we preferred for the study, would help us unpack these complexities that shape the manner in which healthcare is delivered and look at the different subsystems that interact to deliver services, the different actors, and how these are related to long-term control, disease control goals. So evaluating these ethical dimensions really provides us with a basis to say that we are going to be adaptive to the contextual factors that are arising as they arise, and also will help us make sure that at the end of the day, we are making sure that we're delivering equitable services and we're not exacerbating those existing inequities that make vulnerable communities have poorer health outcomes. So for our objectives, our overall objective was to look at how ethical principles have shaped health system readiness and the implementation of COVID-19 interventions in Zambia. And as we used a health systems approach. So we reviewed we wanted to review ethical considerations incorporated into national and subnational policy documents and guidelines. We also wanted to look at how ethical principles have influenced decision-making processes when it comes to priority setting and resource allocation, both at national and subnational levels. Then we also wanted to explore how ethical concerns have guided leadership and governance, as well as shaped multi-sectoral coordination in response to the rising number of cases. And finally, we also wanted to explore how ethics has shaped the implementation climate and the adoption of different interventions at primary healthcare level and within community settings. So in essence, we just wanted to see whether there's a clear and explicit planning for incorporating ethical consideration in policy and implementation of measures. So for our conceptual framework, we integrated two frameworks. So first, we wanted to move away from the modern bioethics approach of thinking about ethics, where we are centered on individual related considerations such as preservation of individual autonomy in terms of access to treatment and things like that, to a more community and whole society level. So in using a public health ethics framework, the emphasis is on maximizing the health and ensuring that the benefits that are derived from the measures that are being put in place are geared towards promoting the overall health of the population rather than the individual. So under this public health ethics framework, we evaluated different ethical principles, so beneficence, autonomy, health maximization, justice, and efficiency. So we incorporated that into WHO's strategic framework on epidemic preparedness, which provides an index through which we can measure emergency preparedness based on 3 overarching domains, which is the governance, the existing capacities to respond to emergencies, and the available resources, so be they financial, human resource, or supply chain and logistics mechanisms. And so we evaluated how all this come into play and result into how the response is currently in play. So in order to answer our objectives, we utilize a mixed method study design in which a larger component of the work was qualitative in nature. And we trained our enumerators and collected data between the 7th and the 26th of March this year. And we combined different approaches to the data collection process. So we did document reviews of key policies, legislations, and guidelines. We did key informant interviews with stakeholders in different levels of the health systems. And we also did in-depth interviews. So prior to data collection, we received ethical approval both from IRES, and we got approval from the NHRA as well. And to be able to answer our questions, we utilized a mix of both content and thematic analysis that was based on the things that we had identified based on our conceptual framework, and then integrated all the data that we collected, both quantitative and qualitative, using a narrative synthesis approach. We collected data in 2 districts, Lusaka and Nakonde, and these 2 districts were selected conveniently based on the fact that at the time at which we're designing the study, a large proportion of the cases that were being observed were in Lusaka and Nakonde. And we also wanted to have a mix of both a rural and an urban type setting. And we also wanted to ensure that the settings that we chose would be able to, we would be able to gather information on a broader scope of intervention, so ranging from interventions that are linked to point of entry, travel restrictions, surveillance, and so on and so forth. So in selecting our study participants, we made sure that we tried to strike a balance in terms of gender, in terms of location. When talking to community members, we talked to both some of the recovered patients. We ensured that we had some representation of people with disabilities, so that we make sure that our discussions would be able to capture all these nuances of how the response differed based on all this usual axis of inequity. So in terms of beneficence and health maximization, for the purposes of our analysis, we defined beneficence as looking at benefits that are to be distributed to the society as a collective whole. So when deciding on which interventions or which measures to put in place, we looked at how decision-making tried to work towards making sure that whatever measures are put in place, they promote the health of a large number of people at population level. And in terms of health maximization, which I had mentioned previously, the goal for measures is to ensure that you maximize the health benefits to as many people in the community or in the society as possible. And in our content analysis, we found that a majority of the policies and the statutory instruments that we reviewed, they really emphasize the importance of emergency preparedness in promoting health and well-being of the citizens of Zambia. For instance, in the National Health Policy, it's clearly articulated that public health surveillance is one of the areas where there is a concerted effort to try and improve the responsiveness of the health system to respond to natural disasters and disease outbreaks and mitigate the impact of this epidemics within the communities. In terms of how this goes now down into actual realization, the Public Health Act puts in place guidance for measures that can be put in place when disease outbreaks are in play to reduce infection and the impact of disease outbreaks to the public's health. So some of these measures include disinfection of workplaces where suspected cases have been, provision of carriage through ambulatory services where patients who cannot be able to access health facilities without assistance can go, measures such as border closures or quarantine, right? And the policies, the different policies such as the Zambia National Public Health Act, they create budgetary mechanisms that can support the protection and the mounting of an effective response in the occurrence of an epidemic. So some of the funds that are provided include ensuring that we are providing emergency commodities, we are ensuring that victims are well provided. So a lot of the stakeholders were also able to state that they had provided resources. So if you look at the budgeting for the response plan, there's been some level of funds that have been set aside to the response, right? So a lot of stakeholders recognize that COVID goes beyond just the MOH, and it requires a joint or collaborative effort to reduce. But the reasons, some of them also had altruistic reasons for supporting the COVID response because they didn't want disruption to their services. So there's regular collaboration and there's formation of response teams that support implementation across different regions. Some of the social mobilization and awareness raising campaigns were done using community structures such as local radios, but they did not always take into account the needs of the underlying populations who they were meant to serve. So in essence, they also had to counter a lot of misinformation and myths about the disease and that had been spread through online and mainstream media. So that had led to a reduction in the potential of adhering to the measures. So in terms of justice, we evaluate justice as the quality of healthcare should be available and accessible to everyone. And we highlighted the importance of a primary care approach that focuses on equitable delivery. And these policies are really apparent in terms of that. So they prioritize specific populations who should be taken into account, such as women, children, the physically challenged, and the elderly. So these policies provide guidelines, and based on our evaluation, so maybe I could just finish on the justice. So we found that when we talked to the healthcare providers, there are various strategies that they put in place to try and facilitate ensuring that people who actually need the services, who are coming in as patients, are able to have access to preventive measures, such as distributing materials, increasing the number of COVID centers, increasing community outreach, and ensuring that they're trying to provide services in a non-discriminatory way. However, even then, community members would still tell us that in as much as these measures are are effective and they can help, some of them did not have adequate resources to be able to fully buy into them, especially those who are persons with disabilities, because they rely on their families and other community members for support. So they would have to work through organizations working within their communities. Mr. Mambo, am I allowed to continue, or should I go into questions?
You can continue for 2 minutes.
Okay. So maybe I could just do a conclusion. So when we looked at, in conclusion, probably the strategies that we're using in terms of doing our health communication and providing IEC materials, we are missing out certain key demographics within the population, such as adolescents, people who are not fully literate, and persons who are living with disabilities, because we're not providing this communication in accessible formats through which they can easily gather information and raise pertinent questions. Our health systems have been overstretched, with health workers being extremely burdened, and we're not doing our best to shelter them in terms of burden of care by providing them with adequate services that can address the psychological distress that they're facing. The shortages in health commodities that we're seeing are hampering the effectiveness of providing maximum health benefits. And some of these shortages are linked to competing health challenges in the country and difficulties in mobilizing resources. Then, due to the poor health infrastructure and inadequate equipment that we have, the quality of services that we are providing are not effective enough, and the quality of services is not adequate, which is hampering the maximization of the health for the public. Then if we are to address some of the myths and fears about COVID, we can help counter and increase the utilization and adoption of these services. And then we need to look at transparency and fairness in the mobilization and the utilization of COVID-19 resources and materials, because this affects the public trust in the health services that we're providing. And it also affects the ease with which public-private partnerships can occur, because the reduction in the accountability of these processes. So some of the limitations that we had is that at the time we were doing the study, there's some aspects of emergency preparedness that we couldn't fully explore, such as vaccines, and we couldn't get adequate information on some of the areas that we were interested in looking at. Yeah, so maybe I can stop there.
Okay, thank you very much, Patricia, for that wonderful presentation. I have been advised that it's better we go straight into the next presentation so that we can take the questions at the same time for both presentations. And just a few announcements as the presentations are going. If you have any questions, kindly type them in the chat box, and while the presenter is waiting to answer the questions, some of them, they can actually be answered from the chat box. So our presenters, you are encouraged to keep your eye on the chat box, especially for you, Patricia, who has already presented, so that you can already answer some of the questions. And then also I have been informed by our IT that we are live on Facebook. So for all of us as we speak, kindly turn on your video so that we can interact and be seen by the outside world, people that are accessing the meeting via our social media platform. And then also just to mention that as we hold this meeting, our dear participants, if you see that there are certain key issues that have come out in the presentation, feel free to reach out to us and tell us what issues stood out for you, and if you think those are important issues that should come out for policy recommendation and consideration. Just to mention that this platform is not just for dissemination, but to help us pick all the noteworthy science that comes out of the studies to be considered for policy implementation. And we do have 2 studies that were 2 out of the many studies that have been presented here that have been considered, and we are currently in the process of developing policy briefs, which will quickly be submitted to the Ministry of Health for consideration. So please, as you listen, pay attention and pick out those key issues. So without much ado, I would like to invite our next presenter by the name of Dr. Oliver Mwemba. Dr. Oliver Mwemba from the University of Zambia School of Public Health comes with a study titled Strengthening the COVID-19 Response in Schools, Experiences from Kafue and Chirundu Districts. Dr. Mwemba, you are welcome. Please put on your video as you begin to speak.
Thank you, Chair. So yeah, I'm going to show my video briefly, and then for connectivity's sake, I'm going to switch it off at some point. Yeah. So yes, I'm going to share the work we have done basically in the 2 districts, basically Kafue and Chirundu. And so the tone of my presentation actually will take more of the advocates kind of tone than a traditional kind of presentation, scientific presentation. Partially, it's because this was a participatory action research, and I think we want to share the processes and some of the experiences we had in working with teachers and PTA members in selected schools in the 2 districts. So I may transgress some of the rules that we actually follow in scientific presentation, but basically it's the nature of the work we actually did. So I just wanted to make sure clear that is I mentioned from the beginning, at least I make that clear. So let me just start, and I'm going to request to turn off the video. So just 1 second. I have to figure out where to turn off the video. Okay, great. Okay, yeah, so we have actually configured our presentation. So I was working with my colleague Mlanda Mlawa, but of course there are many people who have been behind this work, as you see in the acknowledgement. So we've decided to actually pitch the title to actually really use the term strengthen the COVID-19 response in schools, because basically we know there's quite a lot that has been going on in these schools through government and many other partners. Yeah, so basically, even if I put some kind of like a content that actually reflects some of the typical topics in the scientific presentation, but I think what you see mostly are more of pictures and the stories. So I'm actually telling a story just to actually really get a sense of like what did we learn and what do we think would be probably the best way to actually really think going forward in terms of policy or in terms of practice. Yeah, so as we know, COVID-19 is basically right now really affecting all of us And they, in one or another, I think all of us have lost somebody very, very close, and it's a tough time. So what basically, when we actually came up with this project, working with the International Union for Health Promotion and Education, so the thinking at that time was to actually support government efforts in terms of strengthening the response at community level. So this was sometime mid last year. And so we were thinking, where within the community structures would we actually really go, where we can actually supplement what government is doing. So of course, we were one of the countrysides. This study was also in Kenya, South Africa, and Zimbabwe. So, but for Zambia, when we actually looked at what the different initiatives that were going on, we thought we could actually really work with schools. And it came at the time when schools were actually opening up, and I think the government was putting in preparatory work and also coming up with guidelines. So the Ministry of General Education came up with very beautiful guidelines, working with partners like Ministry of Health and of course support from cooperating partners. And so one of the things they actually encouraged as schools were opening was to actually really make sure they actually come up with action plans to operationalize the guidelines in their schools. So the guidelines actually really focus on all the issues we already know. So issues on promoting physical distance or social distance, use of face masks, issues of sanitation and hygiene, and health monitoring and disease management. So those are like the domain which actually the guidelines capture. And so as I said, the schools were expected to actually develop action plans to operationalize these guidelines in each of the contexts that the schools existed. So what we did was to try and see how we can actually really support selected schools to actually come up with action plans. Using a participatory model. Actually, as you see later, we use a participatory workshop model and combined with a few traditional qualitative methods. So, and also with the little funding we had, it was a small project. In Zambia, actually, it was a pilot. We actually gave each of the schools, the 10 schools, about 8,400 startup to actually implement action plans. So they had to work their budgets within that. I have to admit that some of the schools, of course, came up with some kind of long-term plans, some of which we could not actually fund and maybe from somewhere. So we didn't limit the process. So what I want to present here is actually to highlight the process, activities, and experiences of teachers, PTA members in the development and implementation of these action plans, which basically reflected the Ministry of General Education guidelines. So we actually worked within this framework, the REAM framework, so which actually really has 5 domains. So there's the REACH, which is implementation and participation of community members in activities to prevent COVID-19. So I think we are looking at issues of like how many activities will be implemented, and also the level of participation, and also it was a participatory action research, so it would not actually really measure effectiveness, but still would get a sense of like, is there some indications of people having improved knowledge, engaging in positive behaviors? Are we still seeing any negative behaviors? So adoption, if you have seen adoption and maintenance, I've actually blacked them out. We could not actually really capture them within this project. It was a very simple, small one, only actually reaching 10 schools, 5 in each of the districts. And of course, we are interested also in implementation, the extent to which intervention was is implemented. But of course, in this context, the real world was actually only limited to these 10 schools. So there's a bit more that can be talked about. Is there anything that we can learn from these 10 schools to actually roll out to other schools? Yeah, so as I said, 10 schools were actually purposely selected. So we actually really got advice working with Deb's office on which schools we can actually really focus our efforts. So we had in Kafue 5 schools actually which were in the Chiawa area, and at that time we actually went to the Kafue district office. They advised that there was nothing much that was happening in those areas, whereas a lot of urban schools had got some support from other partners like UNICEF and all that. So I think there's that's how we actually ended up in that area. And then in Chilundu also, those are some of the schools that were actually really prioritized: Mandenga, Pembere, Njane, Nyanzara, and Chilundu. Yeah. So what we did, as I said, this was a participatory action research. So it involved a participatory workshop, which included 9 teachers and PTA members from 10 schools. So actually, I invited 4 members, 2 teachers and 2 PTA members from each of the schools to come for this participatory workshop. Yeah. So we made sure, of course, there was gender representation. So the head teachers selected, and we had some good representation in terms of gender. And then, so what we started by, as we are preparing for this workshop, we did a learning needs assessment, and so that we just actually learn what are some of the gaps in terms of knowledge around COVID-19, and also focusing basically knowledge, prevention, as well as basically what corrective measures could be put in place. Yeah. So then we had, when we started the workshop, then we had presentations from COVID-19 from Ministry of Health, and of course UNZA officials also participated in this, and then also presentations on the guidelines from Ministry of General Education, and also a school situation analysis, which we actually did at the beginning of the workshop, and then development of school work plans based on Ministry of General Education. And then we also made sure there was monitoring visits from the district teams, mostly from DMO's office as well as DEB's office. Yeah. Okay, so, and then at the end of the project, we, using a phenomenological approach, we actually made sure we did interviews on the experience of teachers and PTA members who participated in this, in the project. And of course, key informant interviews from district health officials, as well as education officials who were actually involved in the project. So, and then, of course, data analysis for the learning needs assessment, it was more descriptive analysis. So this was a small population, and we didn't intend to actually do complex analysis. It was a small study. And then we also did participatory analysis within the workshop, as well as thematic analysis for interview data. So this study was cleared UNZA break and also National Health Research Ethics Committee. So I just thought I can say something on the learning needs assessment, what we actually learned from the participants. So we, in terms of what they thought, how coronavirus was actually spread. So you could actually see that they were aware on some of the issues like droplets and all that, but they also thought it could actually come through mosquito bite. There are people who thought like that. And also the people thought it was airborne. So, and then how it can be prevented, they literally captured most of the things. But as you can see, there are people who talk about cooking meat and eggs well and all that. So, and then what are the main symptoms? So they were able to actually capture most of them, but there are people who still didn't know. So I think basically we can say there was some basic knowledge, but also there are still some gaps. And then is the situation analysis actually viewed basically what I presented here is a deficit analysis, but we also did a resource analysis, like what did the schools have and what did they not have in view of the domains that actually the guidelines were, the Ministry of General Education guidelines were actually focusing. So in terms of physical distance, what you actually really see mostly space for learning and issues of desks, as well as a physical space sometimes not being observed. And of course, the challenges with wearing face masks. And then, of course, the teachers really were challenged to teach while wearing face masks. And then sometimes they were not worn correctly and consistently. And then some pupils actually didn't have any face masks, and some people exchanged face masks, and they also issues around disposal is something that actually was raised. And then in terms of hygiene, there's some schools reported inadequate hand washing facilities and also insufficient toilets. So basically, this was actually seen particularly with community schools. We had 2 community schools which actually we worked with. And then there was also limited information in terms of health education and also inadequate materials at that particular time. The situation may be different now, and limited education programs in schools and surrounding communities. And of course, disease monitoring, it was not done regularly, so there was lack of equipment at that time. And then disease management, also they talked about inadequate training on recognizing disease symptoms and management of disease, and also no facilities for emergency response or evacuations. And so then in terms of implementation, in view of trying to address some of those deficits or gaps we actually saw, so basically they tried, the schools tried to actually do what they could within their context. So rearranging classroom dormitory settings to ensure physical distancing, dividing of classes to ensure a few people in class. And then in use of masks, they actually bought, with a small budget, we gave them both face masks. We were able to give those people who could not afford, and conducted demonstrations on hand washing and correct use of masks, and the appointment of mask prefects to ensure compliance among learners. Actually, some schools did that. And then they distributed hand washing, chlorine disinfectants and the basins, and also conducted demonstrations on hand washing and correct use of masks. And some of our officials from DMO's office actually went on the ground in these schools to demonstrate that. And some schools actually also built latrines for girls and boys, which actually were not existing, or actually were inadequate at the time we went, and then repaired boreholes and water pumps. And then in terms of health education, they did sensitization programs. Schools are very creative. Actually, we had teachers who had music background, and they did some songs, drama, poetry, and also really did some handwritten posters at that time, because some of the materials were not there, based on the things they learned. And they would invite the health workers to provide health education. So they consulted with the district health workers to make sure that the information was accurate, and designing posters in classrooms, handwritten posters, and also integrating COVID-19 in routine teaching, like when they are teaching on diseases. And of course, most of them bought thermometers, which were doing monitoring in the morning. So these are just some of the pictures to just give you a sense of some of the work that have been done. So one of the schools, actually, they are showing some of the basins they actually bought. And the T-shirt here talking about COVID-19 protocol on my right, avoiding touching. So they actually provide to say, men, mouth, eyes, nose. So avoid touching men, meaning mouth, eyes, nose. Instead, follow women. Wash, observe, mask, exercise, no unnecessary visits. So they were able to actually really work around things that people are aware. So using the men, women, and then they were able to, like, let's say, just a picture of people doing drama. The young people were able to come up with some interesting songs. Yeah, and you could see this is a community school on my bottom right. So you can see the school, of course, is struggling with desks, but they were trying to do the best they could to make sure there was distance and all that. And yeah, pupils are masking and all that. And these are just pictures to show you some of the toilets, the latrines they were able to build from the work, and the repaired borehole and hand pump, which actually was down. And the creativity, you can see on a tree there, COVID-19 will stay a meter apart in one of the schools. So this was, for the toilets, this was one of the visits we did when we actually went on the ground. So this actually shows also like how they were able to actually really, you just using hand drawing, like on the top left, able to show the correct way of wearing a mask, that the nose should not be out. So they will put an X on top to say no, and then a tick there. And that's what is a similar concept on how do you cough, basically on the right. And basically, these are down here just trying to show some of the things schools were able to improvise. And of course, a young boy there washing their hands. Of course, there were some challenges. I think basically resistance and skepticism at that particular time was real. And one of the teachers actually said one thing on the school part, everything went well, but on the community part, because they also reached on the surrounding community through the PTA mechanism. And most people had misconceptions. Some homes who actually really didn't want to even give them space. And maintaining social distance really was a big issue. As you could see, some of the schools were actually really congested, and this is actually what one of the teachers is trying to talk about, like days. So even when they try to separate classes and all that, it was better. Of course, water supply is a real thing also that actually came out. I think in terms of our concluding remarks, so I think schools present a good environment for fighting COVID-19 and strengthen information needs among pupils, teachers, and PTA. Particularly, the PTA is a very strategic structure that I think has been there for a long time, and I think we can actually really utilize it in terms of reaching the parents and the surrounding communities. And it was very, very useful to have them there. And actually, they actually really did a good job. With adequate support, teachers, pupils, PTA members actually really can help reach out immediate communities, and implementing of some of the guidelines still remains of challenges for some schools, especially community schools. They need support because I think in most cases you find sometimes they don't even have desks and all that, and we have quite a lot of vulnerable children there. And I think participatory action research have potential to provide information and capacity for actors to come up with locally driven and immediate actions, especially in epidemics such as COVID-19. So I think this usually is good because it leaves capacity in the community, and it actually leaves a long-lasting legacy that actually can be utilized for any other interventions that may come in future. And that way the community become self-owning, and they can actually really be able to respond for future epidemics. So Ministry of Health and partners, I think, may actually really think, what can we learn from these 10 schools, and is there potential that we can roll out to other schools? There are other schools that we didn't actually reach, that were far and we could not touch, that may still want some of these. So I don't think I have time. It was just some to show you some of the, basically this is a poem from these pupils, but I can only show if it's asset. So maybe for now I'll skip it because I don't have time. Yeah. So I think I would like to acknowledge, of course, we had an advisory committee, which include the Dean of School Public Health, but also the director from Ministry of General Education, the director for School Health and Nutrition Programs, and of course, Dr. Kalangwa, Assistant Director for Health Promotion, Dr. Mlenga. Now I think retired, but I've seen him is on the call. And some of the people are on this call. And also workshop trainers, we had 2 people from Ministry of Health, Florence Kabinga, and Ms. Rose Masilani, Dr. Wilbrod Mutale, and Ms. Patricia Mbita. And of course, the DEBS offices, the DM offices that actually supported us, and particularly the people we worked with, Ms. Clementina Msonda from Kafue, and Ms. Jene from Chilundu, Godwin Msanje from Chilundu, and also Ms. Mwewa. And of course, my team from School Public Health. Thank you.
Thank you so much, Dr. Mwemba, for that interesting presentation. In the interest of time, we will go straight into the question and answer session. Our dear participants, if you have any questions, you can raise your hand. And then we'll invite you to speak. For those that made use of the chat box, I can see we have, I think, 2 questions or so in the chat box. So we can already get our presenters to respond to the questions. So when you type your questions, for those that are typing, please mention to whom that question is directed, and then the presenter or their team members will respond to your questions. So for now, I see no hand, but we've got some questions in the chat box. So Patricia, are you able to respond? I see that you haven't responded in the chat, but you can directly respond here. Patricia?
Hi, let me just read.
Okay. While Patricia is reading, if we have any burning questions or comments, please feel free to bring forth your concerns or questions. While she's still reading, I think I have a question for you, Dr. Mwemba. Thanks again for your presentation. And I see that in your conclusion, you made a number of conclusions, and I did not see the exact recommendations, although I could make sense of the conclusions. But if you had to make two critical high impact recommendations to be implemented to strengthen the response in schools, what would those two things be? Dr. Mwemba?
Yeah. So I think the first one is that so schools, I think, and teachers, pupils, they're very creative. So I think most of them, they have been given the guidelines from Ministry of General Education. So I think I can really make a recommendation that we support schools to actually really come up with action plans to actually operationalize those guidelines. So if there are any partners here, any people are able to actually really spread such capacities to schools, I think it can be the greatest thing. I think we know now, even schools are closed right now, and they'll be opening very soon. Some of them, the schools are still struggling. So I think if we can roll out the trainings to teachers, and particularly in view of the recent things that are also coming up, vaccines have come on board. So I think it can be a good thing to actually really make sure action plans are actually maybe developed further in each of the schools. Yeah, and then maybe the other one I can talk about is more, I think, it was a small study, of course, but I think my recommendation is if we can actually really do a more formal, bigger study, and that's something we have been trying to talk with my colleague, Dr. Mtare, where we can actually really try to evaluate the impact of these interventions, where we have a more control and intervention sites, and so that we can actually really, for sure, say what really works as a package of intervention schools is this and that. So, of course, usually in such, it's an issue of like, where do we get the funding so that we can actually do that? If the people are interested to work with us, we can actually be happy.
That's interesting. Thank you for those recommendations. Patricia, are you ready?
I am.
Okay,
so the
please.
question is on whether we looked at the ethical aspects related to donation. So we were able to talk to various stakeholders across different sectors. So not just the Ministry of Health, but people at provincial and at district level who are part of district response teams. And there was a shared sense of solidarity in terms of appreciating the fact that if disease control targets are to be, met, there has to be concerted efforts. But if, as I mentioned during the presentation, different stakeholders went in with different motivations. So there are some who explicitly stated that part of the reason why they were supporting control efforts was to make sure that their own programs don't stall, right? So it wasn't necessarily always, we want to make sure that population level benefits are felt. It was more like, my program is going to get stuck if I don't contribute to make a donation. And there were cases where health officials and healthcare providers would tell us that if they felt that an organization was making a donation that was crossing those ethical boundaries, where they were pushing their agenda more than they wanted to serve public good, they would reject those donations. But also there was that whole idea that due to limited transparency in terms of how the donations are spent and how accountability processes are, there was also a bit of hesitancy from some of the stakeholders to provide the kind of support that would be needed for an effective response.
Thank you so much for that. Japhet, is that sufficient? Are you satisfied with the response?
Yes, and the last word is quite not cohesion. Thank you.
Okay, thank you for that. I see no hand. Do we have any questions? Okay. Unless I'm mistaken, no, there's no hand. There's no hand. Okay, so if we don't have any further questions, okay, I see one
Chair,
popping
we
up.
have another, yeah, we have the
Yes.
question in the chat box.
Yes, I've seen a question pop up. So this is a question from Bupe, and it's a question for Patricia. Bupe, maybe you may speak about it so that Patricia can just respond directly. Please go ahead.
Thank you. Thank you. Sorry, I'm not going to put on the video. I'm already sleeping. It's late in the night here. So my question is with regards to affordability of the services. So I've been following what has been happening, and it's saddening because I've had relatives and close friends that had COVID and they had to pay for tests, and even those that were admitted, they had to pay for albumin and other tests. So did you look at affordability? How affordable is this? Imagine somebody who has no money and they are told to pay 250 for to test for Didima and all of those things. So did you consider affordability? And just a follow-up on the question that you were just responding to with regards to donations. We saw a lot of donations coming in, but we didn't see a change in the trend with regards to the way things were being managed. So as people that were looking at the ethical considerations with regards to health services, I think it was very important to look at that as well, because I'm sure a lot of people have a lot of questions with regards to that. We saw donations, but we didn't see them get to the people. We didn't see a reduction in the costs that people were incurring because of COVID. So yeah, that's my question. Thank you.
Okay, I would like to apologize. We underestimated the time that it would take to cover some of the components of our study. So there was an entire section on non-maleficence that I really didn't get to present. And under that section, we explored issues related to resource allocation and also related to affordability and how that hampers the likelihood of people who are, because in as much as we say that health services in the country are moderately subsidized, we still find that there are a lot of associated costs related to accessing testing, because in some of the locations we went to, they'd say that they don't have adequate diagnostics, they don't have testing kits, and so people would have to look for alternative ways in which to get tested. So in one of the communities where we went to, the community members would tell us that when we go to the facility, there aren't adequate tests. And we've seen other of our family members who have been able to manage it from home. So we've also opted to do it ourselves. So yeah, there was that recognition that cost was very prohibitive for a lot of community members, even in places like Lusaka, where we talk to people in areas like Charleston and Avondale. They tell you that in as much as in areas such as this, we know that there are a lot of hospitals around us, sometimes it's difficult for us to go and get services there. Populations such as persons with disabilities, they'd also say that, aside from just going to get this kind of services, for most of them, they'd also need to consider like getting additional support, someone to accompany them to the facility. So all those added logistics, it made it really impossible for a lot of people to access care. Then from a stakeholder perspective, the surveillance systems in themselves were not robust enough. So they created loopholes like that where people who may have been exposed to COVID-19 cases were not able to be linked to care. Then in terms of irregularities with the donations, I think I mentioned this as one of the recommendations, that even in like the Auditor General's report, even when speaking with stakeholders who are working within response teams, this was one of the largest detriment to coordinated multi-sectoral responses, because there was a feeling that even as much as all these resources are being delivered, all these donations are being made across the board, because of limited accountability, they didn't feel like they're reaching, as you've mentioned, the people who actually need to utilize them. So you're very right in your observations. Thank you.
Thank you
One
for
last,
the response.
Sandra,
Yeah.
one last contribution towards the response that Patricia has just given. And I think moving forward as a country, we need to be bringing out those issues. So Patricia, those were very important issues that we needed to have discussed in this meeting, I would say, rather than us trying to sugarcoat what is not there. So I think, Sandra, we need to strengthen this, and we need to be discussing issues facing people when we are presenting. So I think just moving forward, as when we're doing any of these research, we need to talk about issues that are affecting people and see the way forward, so that Sandra and the team can take it up with the Ministry of Health. Thank you very much.
Thank you so much, Wupe, for your strong contribution. We have another hand from Chris, but just before Chris comes, we have a comment from Dr. Zulu, just commending the two studies that have been presented. So well done to our presenters. Chris, you are welcome.
Thank you very much. I'm sorry, I may not be able to do the video. Actually driving, so yeah. So, but I thought I should just ask just a small minor question to Patricia. So I noticed that when talking about the aspect of justice, so she mentioned that I think with its services were being provided without discrimination. So that caught my attention, because okay, justice, yes, is fairness, but in the cases of like COVID and in these times that we have COVID, and it's specifically, I think, more risky or affects other people differently, like the elderly and maybe people that have underlying conditions. I would expect that maybe the services should be actually provided with some form of discrimination, with a bit more focus, like trying to discriminate against or to try and improve access for people that are older and people that have some underlying conditions, and maybe try to move away from just like fairness in a sense. So I wanted Patricia to say something on that. Yeah, I think that's my question.
So I think what I mentioned there was, when we talked to the service providers, they did point out that a lot of their response is guided by the COVID clinical management guideline, and also the guideline that's currently in place supporting the continuity of services. And they say that according to those guidelines, the way in which they prioritize cases, at least within a health facility setting, is through factoring in patients who are more likely to have severe cases. So in that case, they provided, they stated that they prioritized the elderly and people who have underlying conditions. But the sense I was putting in terms of non-discrimination is within the health facility setting itself, where the environment was not discriminatory in nature. Yeah.
Okay, thank you so much. Wupe, is that a new hand or the same odd one?
Odd one. Thank you, Sandra.
Okay, all right. Okay, so thank you very much to everyone. We have come to the end of our meeting, and I just wish to encourage everybody to look out for our invitation for next meeting so that you could also share your research findings with us. Thank you very much. And I think I'll check with Mambo. Mambo, do you have any announcements just before we close?
No announcements, Madam Didi. I think everything you've already said. Just people being on the lookout for the invitation for the next meetings, and for those who want to present any findings related to COVID, please reach out to us. Thank you.
All right, thank you so much, Mambo, and thanks everyone. From me and the entire NHRA team, we wish to wish you a safe stay in these hard COVID times. So thank you very much and goodbye.